first in Chennai, then it was Chennai and New Delhi, and now for the past 6-7 years, it's been in Bangalore.
Oh, that's nice. Seriously. So I think, sir, we can give it a start.
Okay.
Yeah. In a couple of seconds, you can give it a start. Yes,
All
sir,
right.
we are live.
Okay. It's great to be.
So I would like to introduce to the speaker.
Okay, sure.
Just a second. Okay, after one powerful session, we are having another speaker with us, Dr. Robert J. Miller. Dr. Miller received his BA from New York University and MA from Hofstra University, both in biology. He graduated with honors from New York University College of Dentistry in 1981, where he received International College of Dentists Award for Clinical Excellence, and then completed his residency at Flushing Medical Center in New York City. Dr. Miller is a fellow American College of Dentists, board certified diplomate of American Board of Oral Implantology, honored fellow of the American Academy of Implant Dentistry, diplomate International Congress of Oral Implantologists, fellow Academy of Osseointegration, and much more. So he's having a full-time practice dedicated to implant dentistry and his revision surgery. So I welcome you, sir, moving ahead with your beautiful session with the title, The Use of Autologous Growth Factors in Implant Surgery.
Thank you so much, and welcome everyone. And a little shout out to Kinor Shah. Thank you for the invitation to do this webinar. I'm going to take you through a very, very quick journey in the use of autologous biologics and implant dentistry. This is not meant to be a replacement for taking a full day course in this area. It's not a phlebotomy course. It doesn't teach you how to fabricate the material, but this is just a little treatise, a little primer, if you will, on the use of autologous growth factors. Let me start with this particular slide. It's one of my favorites because this really sums up the base knowledge of everything that we know about wound healing. And the one thing that we know is that in dentistry, we're concerned with days, weeks, sometimes months. But after that, we sort of forget about what happens. But wound healing actually continues out to 1 to 2 years. Full maturation of soft tissue and full mineralization of bone actually takes up to 2 years to occur. And we're always looking to compress treatment time as long as it takes for these pathways to take place. And to give you some examples of how we compress treatment time, when I was in dental school, of course, endodontics was a 3-appointment procedure. We would open up the tooth and drain it and put some medication inside the first visit. We would do the shaping and debridement the second visit. And on the third visit, we would do the obturation. And it would take 3 visits to complete a root canal. Today, we routinely do 1 visit root canals. So that's compression of treatment time. When I was trained in oral implantology, I was trained by the Brandemark protocol, which is basically extract the hopeless teeth, wait for everything to heal completely, then go back in, place your implants under the tissue, wait 6 months undisturbed, then uncover them, put healing abutments on, and go ahead and do your prosthetic reconstruction. Today, we routinely do extraction, immediate implant placement. That's an accepted protocol. But the problem with that, of course, is that there's just so much that you can do to compress treatment time, because we then get caught up in the envelope of the biologic pathways. We can do everything mechanical that we can care to do. But until we have control over the biologic pathways, it's difficult to compress treatment time anymore. So the object is not just to go through all of these pathways that are here, but to do so in less time, get the same clinical outcome, but do it in less time. That's true compression of treatment time, moving everything to the left. And there are 2 essential factors in wound healing. The first one is vasculogenesis or angiogenesis, development of rudimentary blood supply. The second one is that rudimentary blood supply allows regenerative cells to come into the site. And without both of those, we cannot get regeneration of tissue. We're not going to get soft tissue healing or hard tissue regeneration. And if we go back in time and start looking at the process of angiogenesis, what factors are involved in developing the rudimentary blood supply, we can go to the study of stem cells, progenitor cells, and tissue repair. But the question that really begs is, can we re-engineer the biology of tissue? And to that, I submit the answer is yes. In fact, I've been doing it for almost 3 decades. Over 25 years ago, I was trained by Dr. Robert Morrison, oral and maxillofacial surgeon down at University of Miami, on the use of platelet-rich plasma, PRP. And we use that for decades to compress treatment time. And if we look at the sources of wound healing, the original growth factors were isolated back in the 1960s, bone morphogenic protein, BMP. The problem with the recognition that that was a great growth factor for bone growth was that, one, we didn't know exactly how much was necessary to achieve the desired clinical outcome. And two, we didn't have a good delivery vehicle. In fact, for those of us who do growth factor research, if you look at some of the major growth factors, for example, platelet-derived growth factor, important in the development of fibroblasts and closing of wounds, the half-life of PDGF is 2 to 4 minutes in circulating blood, which means that in 10 minutes, all the PDGF that's been expressed by cells is metabolized, it's gone. The half-life of bone morphogenic protein is 24 hours. So after 2 days, all BMP that has been expressed by cells is metabolized. So unless you have a delivery vehicle that can hold either the growth factors or the cells that produce the growth factors in situ and express those over a longer period of time, we're not going to be able to get the kind of clinical outcomes we expect. Next, we had recombinant human growth factors. Recombinant human bone morphogenic protein in the forms of Medtronic's Infuse, recombinant human platelet-derived growth factor in terms of GEM21. And there are others. There's recombinant human fibroblast growth factor, insulin-like growth factor, but they're all singular growth factors, good for a particular pathway or a small segment of the pathway of healing. And unless you have all of the growth factors necessary for development of target tissue, you may actually speed up the beginning, but you may end up with more immature tissue longer because the other growth factors have to catch up. Next, we went on to the growth factors known today as autologous growth factors, platelet-rich plasma, plasma-rich in growth factors, stem cells, and the second generation material, leukocyte-containing platelet-rich fibrin. And now if we look at all the events that take place early in wound healing, attracting certain cells that are instrumental in cleaning up a wound site and getting initial healing, such as monocytes, it's 3 growth factors together that work to do that. If we look at angiogenesis, sure, vascular endothelial growth factor is extremely important, but there are other growth factors in conjunction with VEGF that are responsible for that. Collagen synthesis, whether it's for the growth of fibroblasts or whether it's the precursor to bone, is also a combination of growth factors. So it's not a singular growth factor, it's a combination of these. And the best way to do that is not through commercially available growth factors, but in the use of autologous materials. So we know now that fibrin, a fibrin clot, is the naturally optimized carrier for the delivery of these growth factors. And all known clinical applications are a response to the following: effective neovascularization, angiogenesis, development of rudimentary blood supply, accelerated wound closure. You'll find that if you've used PRF before, you know that your wounds heal much more quickly. Your incision sites anastomose much more quickly. Tissue heals and matures much more quickly, faster tissue remodeling. And we also get a nearly total absence of infectious events. And we cannot get that with commercially available growth factors. Just quickly, the difference between PRP versus PRGF versus LPRF. And in PRP, of course, we had to take 60 to 120 mLs of blood. Because we were drawing so much blood, we'd have to have an anticoagulant within the tube to prevent coagulation of the blood before we could use it. And because it was anticoagulated, then we had to make it into a usable form, which was a hydrogel. And to do that, we had to introduce a chemical, calcium chloride. And then we wanted to make sure that within that hydrogel, the platelets released their growth factors. And we did that by adding bovine thrombin. So 3 chemicals were necessary to get PRP to work. Then there was Eduardo Anito's protocol for plasma-rich and growth factors. And he was the first to use the fibrin base of that. But Eduardo felt that combining leukocytes would end up giving us too much of an inflammatory response. And yes, if you look at an infected lesion where there's exudate, which is white blood cells, pus, that is a pathogen-mediated response. Now, we're not talking about that. Inflammation is an essential part of wound healing because it helps to dilate the small blood vessels and allows regenerative cells to get there. So for me, not only is a fibrin component necessary to carry cells, but the leukocytes, the white blood cells, are an important part because they're the main reservoir of vascular endothelial growth factors. You want a rudimentary blood supply, you want the white blood cells. So platelet-rich fibrin is what we call a second generation platelet concentrate because it is a leukocyte and platelet-rich material. And if we look at the right photograph, this is what normal whole blood looks like before it coagulates. The red here, of course, is an erythrocyte, a red blood cell. The yellow would be a white blood cell. In this case, this particular one is a lymphocyte. The green with these little arms, those are the platelets, but platelets in circulation become something called activated thrombocytes. They go these little arms, which helps them to connect to one another in a fibrin clot. And the brown circulating around that is fibrinogen, the precursor to fibrin, the fibrin clot. When we initiate a coagulation pathway, we end up with something like this. It looks like a fishing net. And it traps these cells. It doesn't damage them, but by trapping them and keeping them vital, then these cells can continue to release their growth factors over a longer period of time. If you were to use bovine thrombin on these platelets, what would happen is that we'd end up getting a rush of growth factors being released at 7 to 14 hours. But in oral implantology, if we're trying to regrow bone, bone starts to grow at 7 to 14 days. So complete degranulation of the platelets at 7 to 14 hours is not very helpful to us. So by trapping these cells within this fibrin mesh, we allow these platelets, and for that matter, the white blood cells, to release their growth factors at 7 to 14 days or even beyond, at the point where bone growth begins. This is what fibrin would look like if you just had the fibrin itself. But in a physiologic clot, this is what it's going to look like. That fibrin mesh compacted in a centrifuge with the trapped cells inside. And that becomes the ideal carrier because these cells remain vital. And whatever system you use, I'm not here to talk up a system or protocol. I happen to use this one in my practice. I was one of the people responsible for development of this system, so very proud of that fact. But the reason why we want white blood cells is the following. This is a great video called flow cytometry done by a colleague of mine, Dr. Nelson Pinto. We get to lecture each year together at the American Academy of Implant Dentistry. And what you're looking at here is a PRF membrane. It's unfortunate that we have to call it a membrane because when we think of membranes, we think of a collagen membrane. No, it's not a collagen membrane. It doesn't act like a collagen membrane. It only looks like it because it's flattened like a membrane. But in fact, this is a piece of living tissue. It's an autologous tissue graft with live cells. Not only is it live cells, these cells can actually move within the body of that membrane or plug through plasmatic flow. And if we want to look at it under higher magnification, this is what we will find. These are all white blood cells. The lighter cells, which make up about 68% of the leukocyte subfraction, are something called neutrophils. The darker ones in here, with these little horseshoe-shaped components, they're called monocytes. Why do we want monocytes? Because monocytes are the body's first producer of bone morphogenic protein, BMP. If we're trying to regrow bone, that is what we want as a part of our graft. But it only makes up 5% of the leukocyte subfraction. But by centrifuging and concentrating these cells 5 to 10 times, we have the net effect of having 5 to 10 times the amount of monocytes, which means 5 to 10 times the amount of BMP being expressed. So one of our strategies in oral implantology, since bone is the holy grail for us, it holds our implants, then we want to use autologous biologics that have concentrated white blood cells. Then, of course, we have the problem of infection. Now, if you want to go to the old Branimar protocol where everything is healed before you go in there, that's fine. But the patients don't want to wait that long. And if you're going to use extraction-mediated implant placement, this is the battle that we have every single day. Battling pathogens, because pathogens are in the site where we're placing our implants. But why is PRF so important? Because the live cells in PRF will recognize these pathogens. And if we look at this video of a neutrophil phagocytizing this colony of bacteria, it recognizes that they're invaders, that they're foreign. It will wrap its cytoplasm around it, and within minutes, it will completely digest this colony of bacteria. And that is why we have an almost total absence of infectious events post-operatively when we use autologous material containing white blood cells. If we just sum up wound healing in 3 stages, the early 3 stages are the hematoma stage. That's development of a blood clot, and that release of factors from the blood clot is what attracts other cells to the site. Next one is the inflammatory stage. We get dilation of the smooth muscles in the arterioles. It brings in new cells, new growth factors. And those growth factors then produce something called granulation tissue, not granulomas. That's a pathogen-mediated response. Granulation tissue is the first primitive tissue that's formed in the body. And if we look at that in its sequence, and we just allow healing to take place by itself with no help, all healing starts at the hematoma stage. Unavoidable. That's nature. But when we introduce a biologic, in this case, a fibrin-based concentrated growth factor milieu, it does not start at the hematoma stage. It starts midway through the inflammatory stage. Why? Because LPRF contains all of the cells that the early hematoma stage would be attracting. So it takes a couple of weeks to get through the hematoma stage, to get to the inflammatory stage, to bring in the cells that we are now introducing at the day of surgery. Not only are we introducing all of these cells, we're introducing them in concentrated form. So we're already several weeks ahead in our wound healing by simply placing PRF. And that immediately goes on to granulation tissue formation. Of course, you cannot have autologous growth factors without a phlebotomy procedure. And in the phlebotomy procedure, this is my triage that we teach in our phlebotomy courses. And that is that we start with something called the antecubital fossa. 99% of us in the audience have our blood taken from the middle of our arm. That's called the antecubital fossa. The median cubital vein, the cephalic vein, or the basilic vein. If we can't find one there, we might go to the dorsum of the forearm. If we can't find one there, we'll go to the dorsum of the hand. When I was in my residency, they only allowed us to start lines We did a rotation through anesthesiology in the dorsum of the hand because this was the purview of the blood people. They didn't want us screwing up their gold mine, their Alaskan pipeline. If you cannot find anything there, and sometimes you cannot, in non-athletic people with thicker fat layers in their skin, postmenopausal women tend to be like that. Then I go to the dorsum of the foot, either the greater or lesser saphenous vein on the dorsum of the foot. It works beautifully because women tend to wear really tight high heels, and there's no way for that fat layer to grow. So it's a good place to get it. And once or twice a year, I end up going to the dorsum of the foot for that. This is what we're going to look for. We're going to look for the largest vessels. We go parallel to that. And then we draw our blood into vacutainers, red or white tubes, so that we can spin them down, either harvest the fibrinogen in liquid form to make something called sticky bone. I'm sure that you've heard that concept. Or the red tube that allows us to make PRF membranes or plugs. We then centrifuge our tubes and we fractionate the blood, and the blood is fractionated into the following components: the red blood cells at the bottom. We eliminate those. The buffy coat, the pinkish area up in here is where most of the platelets are. The fibrin portion, where a lot of the white blood cells are, but the white blood cells exist all through this fraction. And then the fluid on top is not plasma, it's serum, because it's devoid of cells. And people call this plasma. It is not. It's called serum. Then we take the red top tube. We take the cap off. We'll reach inside, grab a hold of the fibrin component. We don't want to cut this off. We just want to brush it off. If you cut across here to get rid of the red blood cells, you've also eliminated all the platelets that exist inside here. That's what we want to see. The bright red are well-distributed platelets through the body of this fibrin mesh here. Then we're going to place it into a box that will help us to compress it either into a membrane on the perforated platform or a plug in the Delron cylinder. So for those of you who like sushi, I affectionately call this my yellowtail sushi. I know sushi will never look the same to you. We put that on the perforated platform. We put the pressure plate on top. We put the weighted cover on top of that. We wait about 4 minutes, and we don't press on this. We just allow the pressure to very slowly express the serum out of the fibrin clot. And we remove this. We have 2 beautifully formed PRF membranes. Now, this is a piece of autologous living tissue with cells that are migrating through here by plasmatic flow, which would include platelets. Then we have instrumentation to pick this up, carry it to the surgical site. And if we don't want a membrane, if we want a more of a solid piece, we can make what we call a plug by putting it into the Delron cylinder, placing the piston assembly on top of that, and compressing it down to the point where it looks like this. And we're able to place this into an extraction site instead of folding up membranes and trying to manipulate that. This is one solid piece. I like this much better. And you'll note that platelets are more on one side than the other. I like to put the platelet side down into the site first. My last layer is going to be platelet side up, so I get fibroblasts to go across the top of that. Then there's serum that expresses out of this material. We collect this serum, and then we can hydrate our graft material with it. And this serum, not plasma, this serum contains already expressed growth factors. It also enhances the handling characteristics of these. And then through the years, we were playing with some kind of scenarios. Sometimes we'd place uncoagulated plasma into our particular graft material. And then by accident, we found that this was coagulating the particulate. This was before we had a name for it. Today, it's known as sticky bone or sticky bone or PRF block, whatever system you're working with. But it enhances its handling characteristics. And when we do so, we can then place them on the outside of thin ridges. Instead of inside an extraction site or around an implant, we can actually augment the volume of a ridge. We can use tenting screws in here. We can cover it with collagen membranes. And then we don't have to worry about migration of the particulate. So this is a way for us to enhance the thickness of a ridge without having to go through major protocols. When we place implants, especially in thinner ridges, we always have to worry about dehiscence or resorption of these thin facial plates. And I'm sure for those of you who have been in implant dentistry long enough, you've had the experience of over time seeing the grayness of an implant show through. That's resorption of these thin facial plates. So if we know we're in a thin ridge category, what we'll do is we'll tunnel underneath there. We will actually place that sticky bone component on the outside of that. And that way we can thicken up the tissue and the bone so we don't have to worry about dehiscence defects around our implants. And this is actually what the early stages of coagulation look like. We'll take a particulate material and you're watching in real time as the fibrinogen, the uncoagulated material, then forms a fibrin clot, but coagulates all the bone material within that. So it enhances the handling characteristics and prevents migration of the tissue. Now we're going to use this in a surgical site. And in this particular case, I was actually doing a peri-implantitis treatment. I'm going to skip ahead here. Here we go. This is something that we see more and more often today. Implants that were done years ago are starting to develop bone loss and infections around them. But we can actually regenerate these now. We have to flap them open. Don't try this closed flap. It's not going to work. We open these up, remove all the granulation tissue, completely debride the implant surface and remove all the granulation tissue that's there. This particular laser is from BioLase Technologies. This is the erbium chromium YSGG. It's 2780 nanometers. I've been using this for the past 23 years, this wavelength. It's my go-to instrument whenever I'm doing any kind of debridement. Whether it's an extraction site, infected bone, removal of diseased tissue, or in this case, the debridement of an implant surface to just prior to grafting. Because in order to get a graft to regenerate bone onto the implant surface, it has to be surgically clean. I'm not so much worried about sterile. As long as it's surgically clean, you've removed all the bioburden, you're going to be in good shape. And I will tell you that if we look at this under the scanning electron microscope, it is basically sterilized. And any red tissue is going to be removed. Because any red tissue is going to be granulation tissue. That's pathogen-mediated granulation tissue. And then we get decortication. Look at the bleeding in the site. That's what I want to see. And here's the fibrinolized bone. And then we're going to place this onto the implant site. We're going to compact it. And because it's no longer really particulate, not separate pieces, it's one fibrin mass. And this will not migrate. Not only will it not migrate, but you don't have to worry about salivary contamination because fibrin becomes cell occlusive. It won't resorb, it won't wash out in the presence of saliva. We do this circumferentially around the implant. We cover it with one final PRF membrane. And then we close this. And this is a 1 week post-op of this case. Look at the beautiful healing at 1 week. And we look at these cases a few months later and see the beautiful regeneration of bone around these ailing implants. So what are the clinical applications of PRF? I can't go through that in the time that we have remaining. I just sort of mention them. Extraction site management, immediate implants, ridge augmentation, sinus foil elevation, implant repair, even the use of this alone in place of palatal donor site subepithelial connective tissue for the treatment of mucosal defects. Extraction treatment. People will always argue with me that they do not believe that PRF actually regrows bone. Well, there's a wonderful growth factor summit that's held every couple of years in Leuven, Belgium. And the top researchers in PRF go there to share their current research. This was from the first conference that they had. What they did was they did a micro CT analysis of bone defects. One where they just had bleeding. They would take out the teeth, cover it with a membrane, but put no biomaterial inside. Then did the micro CT to see what kind of density of bone they would get after a few months. And this is an example of the density of that bone. But when they put PRF in a site, and then they went back in the same time frame and looked at the micro CT, this is the density that they got. So we were seeing things empirically day after day, year after year, using PRF alone as our graft material, knowing that it grew bone. But this is the first time when they've actually been able to show that in situ before reentry and show the difference between natural healing and natural guided regeneration with concentrated growth factors. Now, here's a site where I had just placed a graft, but when I took the final periapical radiograph, I noted that there was a lesion on this tooth. It was fractured. So I had to apprise the patient of that. We extracted the tooth. We did the debridement. Here, make sure that you're always removing any pathologic tissue that we find apically or anywhere else for that matter. You don't want to place a graft material or PRF in an area that's super infected, as good as it is. Remove all the granulation tissue. And I love lasers. I don't care what you use. To remove the inner lining of the sulcus, you can use a laser. You can use fine diamonds. You can cut it out with a scalpel, a very fine scalpel. Go down and make sure you've completely debrided the apical areas. And then here, what I'm going to do is I'm going to add a bone graft, but I don't like particular bone graft. I like what we call composite bone grafts. And whether it's a particulate that I've fibrinolized, or in this case, I'm using something called an osteogen bone plug from the Implant company in New York. It's a collagen plug where you can see a bone graft that's embedded inside. Then I will hydrate this, not with whole blood, not with saline, but with plasma that contains all the live cells. So what it does is it creates a PRF membrane embedded within the graft material. You see how beautifully this handles, and just compress it down to just below the tissue level. And we want that tissue to grow over that. We do not use a collagen membrane. I do not even need to place a final PRF membrane over this. All I do is a single horizontal mattress suture over the top. And are you going to see the final PRF, the suture here, just like an X suture over the top? That's all we need. We don't have to worry about salivary contamination. The embedded fibrin is cell occlusive and won't allow saliva to creep down inside here. We don't close this primarily. And this is what it looks like at 1 week. Look at the rapid cellular migration over the top of this at 1 week. That's amazing to me. I cannot get this using any other protocol. You want to see bone? Here's an example of using PRF alone as a graft material. And look, I'm a big proponent of endodontics. I have root canals in my own mouth. I would do a root canal before I do anything else in a tooth that's not otherwise hopeless. But unless patients restore their teeth All the root canals in the world are not going to help us. They just continue to decay and wear down. But we're thankful for that, because in this case, endodontics for us has become pre-implant therapy, and it maintains the ridge for us. So this is what it looks like after extraction. It doesn't look like there's a biomaterial there, because PRF does not show up as radiopaque. It's radiolucent. But now I'm going to show you a few months later as we re-enter this zone. First, look at the thickness of the tissue. Look at the vascularity of the tissue. Look at the volume of the bone, and look at the vascularity of the bone. That is what I want to see when I'm going to place my implants. No bone loss, no shrinkage. Look at the vascularity of that. You also don't see any particulate material. That's 100% vital bone. And when we do the core analysis of this, we can have up to 75% vital bone. Look at the vascularity of this in the bleeding site as we're placing these implants. I'm going to skip the rest of this. Enhanced biotype and connective tissue grafting as a substitute for connective tissue by doubling over a PRF membrane, coronally repositioning the flap. This is a beautiful paper done by Jankovic et al. In the International Journal of Perio and Restorative Dentistry. What they did was they did a study where they compared palatal donor site tissue to PRF. And their findings were that there was no difference that could be found between PRF and connective tissue procedures, except for a greater gain in keratinized tissue if you're leaving it exposed. That's it. Otherwise, this is one of their cases in their paper. This is a typical recession defect. This is the two vertical releasings, preparation of the root surface, placement of the PRF membrane with periosteal sutures to hold it in place, coronally repositioning the flap. This is what it looks like at 7 days, and this is what it looks like at 6 months. Exactly the same as palatal donor tissue. So wherever possible, we don't need a secondary surgical site for these cases. Ridge grafts. Here's a typical BW ridge, a knife-edged ridge, complete loss of the facial all the way to the lingual side, too thin to place implants. What we're going to do in this case is we're going to graft this. But this particular case, all I used was tenting screws. Now, these tenting screws are placed where I want my final outside contour of the bone to be, right here. And these screws are 5 millimeters off the bone. How do we know that? My assistant will be bringing her suction tip into the site in a moment. And you can see the suction tip fits underneath the top of this tenting screw. So you'll know exactly how far it is off the bone. There it is. It's underneath that. That's the distance I've got to regrow. Then I'm going to place my bone graft material, hydrated in autologous plasma. We cover it with a collagen membrane. All one-wall defects always get an outer layer of collagen because I want that to be preserved without any microtrauma. Final layers are always PRF. We want as quick a closure of that site as we can get. We do a periosteal release for primary closure and a combination of interrupted and horizontal mattress sutures. Then we're going to wait. I like to wait 5 to 6 months in these big graft areas because I not only have a lot of bone to regrow, I want the best quality of bone when I re-enter. So this is about 5.5 to 6 months later. This is our re-entry. And the first thing you're going to note is the conspicuous absence of residual bone graft material because I use fully resorbable bone graft. This is the original ridge back here. All of this is regenerated bone. It's a 12 millimeter wide ridge. I can place 6 millimeter implants in here with 3 millimeters on either side of it. Watch the bleeding when I remove this tenting screw. Look at the vascularity of this grafted area right here. I'm taking my 6 millimeter final drill, and you'll note the density of the bone that I'm cutting through. No bone graft residual. Look at the vascularity when I remove the screw. Here, look at the vascularity here prior to placing my implant. Now the implant's going in wet. It's going in wet because I always dip my implants into the serum box. This is called the conditioning of your implants. And I'll explain what that is in a moment. We're going to go ahead and place this to its final seating position. And after our first implant is placed, I'll place a secondary implant posterior to that. Look at the quality of that bone. This is all grafted and regenerated bone. And a second implant back here. And I'm going to skip this. This is a few weeks after healing. Look at the quality of the tissue that we're regenerating. Look at the thickness of the tissue. Look at the quality and color of this. And this picture represents a 1 year post-op. Original knife edge ridge to full ridge with 2 6mm implants and beautiful band of keratinized tissue with papillary support that has not shrunken back. Sinus grafts. This is done by a dear friend of mine, Dr. Ziv Mazor from Israel, where he did a paper that they published in the Journal of Implant Dentistry, the ICOI. This is a very thin sinus wall. He loves to do immediate implant placement, even in ridges with less than 4 millimeters of bone. So these are the pictures from his paper: Piezo Surgery, lateral window, rotating it coronally, placement of the implants, and then placement of nothing but PRF, not biomaterial, just PRF in these sites. And a final PRF membrane on the outside. No other foreign biomaterial. Then they take a 6-month CT scan. And at 6 months, this is what the case looks like. Here's the window that was rotated coronally, still there. But look at the bone that has grown here. Look at the high mineralization of this bone. And you can only get them, let me go back. You can only get that with PRF. Otherwise, you'd see particulate material remaining here. And you'll end up with up to 75% volatile bone. That's what I want in posterior maxilla. So from a radiologic and histological point of view, we're able to stabilize a high volume of natural regenerated bone right up to the apex of the implants. I mentioned a moment ago that I like to dip my implants into the serum box. This is called bioconditioning of your implant surface. Beautiful paper published from Iran. And this is an example of how we do this. We'll take the implant, we'll place it into the serum, rotate it so it's completely immersed, and then we will deliver this in situ. And why do we do this? Because some implant surfaces are hydrophobic. They repel fluid, and you actually get a delay of the attachment of bone cells to that. So by conditioning this, by putting tissue adhesion proteins on here and growth factors, we're attracting the bone cells that much more quickly. And their paper suggests that there's an increase, they can measure an increase of the bone marker protein called alkaline phosphatase. And that is a beautiful marker. There's about 6 different ones that we can use, but alkaline phosphatase is the oldest one, and we can actually measure how much bone we're regrowing in what period of time by measuring how much ALP is present.
Sorry to interrupt, but I would like to inform you that the session is left only for 10 minutes and it might over on its own. So
okay,
can
I'll be finished.
Accelerate?
I'll be finished in 10 minutes.
Okay, sir. Thank you.
All right. Here's a typical kind of case where we have a fracture of a central incisor. And in this case, what we're going to do is we're going to do the newer protocol is going to do a socket shield wherever I have endodontically treated teeth and the root is ankylosed to the bone in the premaxilla. I love to do socket shields in these cases. Here's the socket shield left in place. I'm going to go ahead and debride this. And again, I don't care what you use. I love lasers. I can't say enough about it. This is my go-to instrument. Removing any remnants of apical granulomas, any remnants of periodontal ligament, and any remnants of bacterial flora in the sulcus. Then I'll go ahead and prepare osteotomy, place our implant. The implant goes in wet. It's conditioned with serum. And we're going to place it 2.5 millimeters below the gingival zenith, which is right here. That top of that green band is exactly 2.5 millimeters off of the implant platform. So I know exactly when I'm at that point. So here's our gap. I put a cover screw in, and what do I put into the gap here? I put PRF. I don't want biomaterial where I have a socket shield. I don't need it. So here we're going to take our PRF. We're basically just going to put that into the open area. Then what I can do is I'll skip ahead here a little bit. I can place my provisional abutment on here, place my PRF circumferentially, and then I can prep these and place a provisional on here out of function. We do not want these in any type of function. Centric, protrusive, lateral excursions, because there's not enough bone to hold these implants in. And we place a nice provisional on top of that. This is the delivery of the final case. Look at the beautiful preservation of this facial plate. I'm using a little antibiotic ointment in here prior to placing my final abutment. Here's the final abutment, which we torqued to 35 Newton centimeters. And then our delivery of our final crown. And these are the protocols that I love using in the premaxilla. Final case I'm going to show you, typical trauma case that we treat in my practice. We have a lot of older patients, and they tend to do a lot of falls and face plants. So here's a patient who called me up from the emergency room in a hospital across the street from my practice at 4 o'clock in the morning. Met him at my office at 4:30. That we were able to start closing this. This is just, I'm going to go through this quickly. It's a double layer closure of the pedicled lip. I'll skip ahead a little bit. And one of the things that I do, though, is I always place PRF on the outer epithelium. I'm not worried about scarring on the inside of the flap. I'm worried about scarring on the outside. So I place the PRF on the outside. This is what it looks like in 1 week. And you might say, well, this doesn't look too good at 1 week. I said, no, just the opposite. Look at all that cellular activity. You never see this on healed skin at all. You only see it intraorally on the mucosal side. This is a 2-week post-op. This is a 3-week post-op. And then we start the process of placing the implants. These are 2 fractured teeth. And I'll just skip ahead here a little bit. I can't do a socket shield here because the teeth are mobile. Once they're mobile, the whole thing comes out. We place our implants, debride the area, and then we place PRF membranes in that gap. And we have specialized instruments to do that. These curved instruments. They're actually composite instruments that I've adapted for the use in surgery because it fits perfectly in here. Hugh Freedy makes these. That's what it looks like. And then this is the final case, healed lip. I put a crown here, and these are the 2 implant crowns on these 2 teeth. So I think I've actually finished on time, and I always try to get through these short webinars on something like this. But I think, and I hope I've sort of whet your appetite to take one of our full day programs wherever they are at some of the big conferences, whether it's American Academy of Implant Dentistry, International Congress of Oral Implantologists, Academy of Osseointegration, or some of the courses done by some of the implant companies such as BioHorizons. I don't know now that my lecture is done, I don't know if we have time for any questions and answers. I don't know what your platform is going to allow right now, but I'll turn it back to the moderator.
So definitely, it has been quite an informative lecture for everyone, and I was so amazed seeing all those amazing cases by you. So thank you so much for that. And with that, we'll move on to first question, that is by Dr. Warufalla. Can you please tell alternative to laser for cleaning implant surface?
Yes, you can use Piezo Surgery. You can use round burrs. You can use diamonds. Doesn't matter what you use, you just debride the inside. The object is to get rid of all apical pathology, get rid of all traces of periodontal ligament, and to completely remove the inner sulcus, because in terms of periodontal infections, they are resident in the sulcus. That's why they're red. That's why they bleed. All red gingival tissue is removed. All pathology in the bone is removed. If you don't have a laser, then I would recommend you do one more thing, and that is get aqueous metronidazole, 5 milligrams per ml, and irrigate your osteotomy before you place your graft material on your implant.
So can all these substitutes be like changing the surface of the implant? Like, will they alter the surface of the implant, or any sort of problem will be there in osseointegration?
No, it won't. It won't alter the surface of the implant as well. But the thing about the PRF is that it will accelerate the attachment of cells to the surface. It's kind of a technical explanation, because there's a certain electron state of titanium oxide, and you can alter that electron state by either attaching organic material or by treating them with lasers. And it's one of my research projects right now that we have a new laser wavelength that we're actually going to be able to alter the implant surface to make it go from being hydrophobic to being hydrophilic, so we get a far faster attachment of blood and its components.
Okay, thank you, sir. We have another question from Dr. Anirban. What is the name of human thrombin?
The name of human thrombin?
Yeah, the question is being put up by Dr. Anirban.
Well, it's called thrombin, but what we're doing is we're converting prothrombin to thrombin within the body, and that thrombin then causes fibrinogen to become fibrin. So it's a natural process that takes place. It has not yet taken place in plasma. That's why we use the white tube to deliver the fibrinogen in liquid form, and then it autocoagulates in the surgical site or in the bone graft material prior to placement.
Yes. And we have another question again from Dr. Anirban. What about G-force in different preparation of PRFs, and how many millimeters from the root membrane is to the immediate implant?
Well, understand that G-force has many effects on blood. G-force, of course, is responsible for the fractionation of blood. It separates out its components. But it also affects the distribution of those cells within the fibrin component. Very low G-forces give you a better cell distribution, because you're not throwing all the cells to one side by higher forces. But low G-forces result in a very poor compaction of fibrin, and the fibrin membranes and plugs don't last as long. So what we do with the intraspin system from BioHorizons is we have a slow ramp up for the first 2 minutes that gives us better cell distribution. And then we go to 2,700 RPM, which is 408 Gs. It's not about RPM, it's about G-force. The same RPM from centrifuge to centrifuge will give you different G-forces. So people just see the number 2,700 RPM. They don't understand it's not about that. It's about G-force. If anyone wants, I have the actual mathematical equation that allows you to determine what your G-force is based on the distance of your tube from the rotor. And the distance now from what to what? The last part of the question?
How many millimeters from the root membrane is to the immediate implant?
I like about 2 millimeters distance, maybe 3, but I've seen people actually come in contact with the root portion. I conceptually have a problem with that because if you have an implant that's being placed in the osteotomy and it starts to exert a little bit more force on the root component, you could potentially fracture out a facial plate. I always like some kind of gap because I want natural bone. I don't want a dentinal wall next to my implant. So the average is going to be about 2 millimeters.
Okay, sir. Thank you so much. And I think we're not having much questions to be asked for. And like people are sending regards to you regarding your surgeries and beautiful results you've shown to us.
Thank you.
Yes, with this, I think, yeah, we don't have much more questions. So thank
All right.
you so much, sir.
Well, thank you
Yes,
for the
sir.
opportunity to present, and I hope that the next time we meet, we can all meet in person.
Definitely, sir. Thank you so much, sir, for the beautiful session you've conducted, the beautiful results and the presentations of the cases.
Thank you so
So
much.
with this, we'll sign off with the session. Thank you, the participants.